Good morning, friends. At the outset, I would like to thank Professor Atul Kumar for giving me this opportunity to be here in this course. I would like to talk to you and share a few things about diabetic macular edema, especially as it is more of a case-based. Maybe that's how I'm going to be dealing with this here also. And we all know that diabetic macular edema is the commonest cause of the moderate visual loss, and it is at the most productive age that this thing happens. And at this time, what we all need to know is that we have to classify it as non-center involving and center involving, and we don't go into those complex things which we were talking earlier. This is something like a non-central involving. This is based mostly OCT based, and the central involving that would appear like this. The problems are non-central involving. I think at this time we are still doing a focal laser. Otherwise, for these cases with the center involving, that is where the challenge lies. I think what the way we deal with it and what we do is we do these blood glucose levels, especially HbA1c and 24-hour urine protein, as well as you need to do lipid profile. And subsequently, these other ones, the ophthalmic things, they can even wait, but the systemic investigations are very important. So why? You need to achieve excellent glycemic control, normalize blood pressure, reduce the serum lipids, and treat anemia and proteinuria, as well as then you go on to other things which are from our point of view. What then you can do intravitreal anti-VEGF steroids with or without focal or a grid laser. And you may need a pars-plana vitrectomy for a taut hyaloid in DME or sometime a combined therapy. So I think this is one of the landmark publications from our center long time back, that if you did good metabolic control, gave something like lipid lowering drugs, and then did laser, and you can say even a worst case like this can have a very good outcome. And this was another study. Raman did this, Ramandeep Singh that time. And you can see this was in diabetic care. And we could very convincingly show. You see, ETDRS just showed 3% visual improvement. And in this, after good metabolic control, we used to wait minimum 6 weeks to 3 months after metabolic, then go for laser. 29% showed visual improvement. So I think that's a very important. I just want to show you some of the example here. Look at this. So these are from that time, 2005. You achieve a good metabolic, this is in 3 months. You look at the dates there. Just in 3 months' time, everything, the lipids have melted away. And if you need to, it is not a one control, not a sugar control. I'm talking of entire metabolic control. That is what. Another example. It's not. We can show you examples upon it. Nothing has been done. Just the metabolic control. So that is you dealing with systemic disease. So that's what the macular edema would appear totally different. So now, subsequently, I have shown these examples before, much older, because the anti-VEGFs came sometime in 2006. So I think we know, I have just put this Cochrane review from 2017, that anti-VEGFs are effective at improving vision in DME, with 3 to 4 in every 10 people likely to experience an improvement of 3 or more lines at 1 year. So I think anti-VEGFs are really working. And most are often undertreated and under-monitored. You see, diabetic are different from AMD. They have many systemic issues. That's how they are under-monitored, and they have multiple issues or treated. And overall safety between the 3 anti-angiogenic drugs appear almost similar. So that is what this Cochrane review says. So like this, 58-year-old, you can see highly uncontrolled. Everything was wrong with him. So much of serous fluid there. And he underwent metabolic control. Then Avastin was given. And then the grid laser was done. So you can see even a case like this would turn around. And you can definitely help such a patient. And that is the way it looked subsequently. I think apart from anti-VEGF, I'll not go into detail, because what we are concerned here is what is the role of steroids? Where can we use it? This is essential, I would say, and adjunctive treatment for refractive and persistent DME. And efficacy is comparable to the anti-VEGFs in pseudophakic eyes. In fact, many a times, even in treatment naive, I tend to give steroids even as a first treatment because it helps for 3 months, and many a time these patients, they do very well. And as an adjunct to cataract surgery is very much required, and cataract and raised intraocular pressures are the problems which in fact we have to monitor these patients. I'll just share you this recent patient. She has come to me after I retired in practice. Recalcitrant DME, 72 years female, pseudophakic both eye. Look at, she received 9 Lucentis in one eye, 8 in other eye, then focal and grade laser. Not only that, during this business, she developed MI and had stenting. So we are not realizing all these things. I think we are responsible. We somehow added that factor to her getting this attack also because she was diabetic. And she was very unhappy. Vision, she would say, marginally it would increase. And she was not ready for any kind of a treatment. She said, no more injections in my eyes because I have spent quite a bit of money. So I don't know why she was not offered Ozurdex. And although it looks bad, you can see these septas, those kind of stretched out things may not do that well, but injected in one eye first, then in second eye, Ozurdex. But you see, why I want to say is, look at this. I think she's such a happy patient, and she says now that I will be coming for treatment only for getting these injections, not the other ones. So why I'm saying this, I think diabetic retinopathy, now you can see even the recurrence here, and we have given the second time also. So what I'm saying is, I think keep your options open. Don't keep on persisting like in this case. She had precisely received 17 Lucentis in both eyes already without doing much good. And because it was already like a chronic, recalcitrant kind of a disease, we had to change our, and this is something, if you do a cataract surgery in such a case, it is already bad. I think this requires intraoperative or a preoperative Ozurdex. This is landmark publication again from our group, which is in ophthalmology, which has shown convincingly, and not only that, this is the trigger point for doing that big study in US, which has changed the guidelines for cataract surgery and DME patients. I'll show you this case is from the trial Illuvian. We contributed maximum number of cases from our center for this trial. I'll just show you. This lasts for 3 years. And this case, you can see, this almost looks like the diabetic retinopathy has disappeared. So if you have something like that, for 3 years, which is not coming here, I think it's expensive. We try, I think we have been told it is anywhere between 8 to 10 lakhs, one injection. So maybe that is where probably the bottleneck is. But it works very well. You can see it almost disappeared in one of these cases. DME surgery, of course, I think it is required in some cases. And like one case here, again, a lady, 624, had Lucentis, had grid laser, had Avastin, and somehow there was that. She was not agreeable for surgery. Always I would tell her that we have to take, this is a sort of a globally adherent membrane there. And once she finally agreed, you see how well she did, even at that stage. And you can see those old laser marks also there on that autofluorescence. So there is a problem. There's economics of diabetic macular edema management. Here, individual pays. I think we have to be very careful. And secondly, be careful about their systemic status. At least my patient, those who were very well off, they wanted to be, many of them, either they develop in between a stroke or a MI. Once you give in both eyes, because you're giving in both eyes, the problem is there. So I think it's not the same ball game as is AMD. Mostly that's not the same. So we need to follow standard of care, but with some riders, and mostly these patients would be undertreated or under-monitored. I think keep that option open of giving steroids. So you need comprehensive control of blood sugar, BP, proteinuria, anemia, everything. I showed you some examples. I think it works, and don't just shoot injections left and right. And anti-VEGF and steroids, combined with laser, they'll help many of these cases, and laser is required for sentinel node DME with anti-VEGF steroid, and this would also decrease number of injections, because even in trials, you must have seen 40 to 45%, they underwent finally laser after 6 months, and the vitreous surgery is required for tractional DME, as I have shown in one of the cases. Thank you very much, ladies and gentlemen.
Thank you very much, sir, for that excellent talk. And he showed us, sir, showed us very nice slides where just the control of diabetes reverse the retinopathy. So that's the key point that we need to control diabetes along with eye treatment. And you have shown beautiful slides that the exudates and everything disappeared. The microaneurysms went down after. So any questions from the audience? 1 or 2 questions? Yes, Dr. Sood. Dr. Sood has been HOD at the GMCH hospital, famous hospital, Government Medical College Hospital at
First,
Chandigarh.
I congratulate you, sir, for your very comprehensive talk. My only query is that you have rightly said that surgery is the treatment of choice in a tractional diabetic macular edema. If surgery has any role in a recalcitrant diabetic macular edema which is non-tractional?
I think I didn't touch upon that. There are studies reported where they have done surgery for such cases. The problem is usually if the patient understands, vision may not improve. But then we also should take analogy from one thing. If the vision is not going down and we can stabilize, I think we did this stabilized business with laser all the time. We would tell them in the era, those days, that we're going to stabilize you. So maybe, I think in a desperate situation, of course, I think there are so many things. It has not really what Prasatul highlights, those tubulations, those stretching things. If those are a lot, then maybe they may not get benefited, and maybe then we need something different. But I think we can try first steroids, maybe sometime combined both the things, and then look at it. And finally, if nothing works, surgery if patient understands.
Thank you, sir.
And a little bit ERM is there. The first shot which we give is steroid only, because if we remove the vitreous and all the things, and you can say after
Absolutely.
that, then no in case of recurrence of
yes.
edema, now there is no vitreous, so giving any injections would be very
Steroids may
difficult.
work in
So-
vitreoretinal.
Yes,
Yeah,
very
so
true.
even for a TOT highlight, the first trial steroid can be.
Absolutely. I would say it is multifactorial as far as the DME is concerned. So maybe you give injection, it will work. You may not need surgery straight away. But if it is not and it is still there, I think then you go to surgery.
If the patient is already a cardiac patient, he had an MI or he had a stenting, PTCA done, do you still go for the Avastins and
No, steroid.
only straight away you go to steroids?
Yeah, as I said, in many pseudophakic, I even tend to give primary, but I would say in such a situation, always steroid. Always, absolutely. You can, even in a poor patient, you can use just 1 to 2 milligram times alone. Don't use 4 milligram. If it
One
is
last question.
situation.
Sir, nowadays the cholesterol is not a more risk factor for CVA. Do you think in diabetic maculopathy is still having a role? And second question is, what the in the continuation of that, in pseudophakic eye, what is your experience? Is the Ozurdex is the first line of the treatment,
Yeah.
not after anti-VEGF?
Yes, that's what I said. If we find that both eyes are pseudophakic and it is lot of edema and it looks like more like chronic, we tend to go more as a first line with Ozurdex if the patient can afford it, but not first line with a triamcinolone. To tell you frank, it is like an atom bomb. You put something and it acts immediately. You need something slow release. That is why we feel more confident using. So in many cases of DME which are coming late, which are chronic and are pseudophakic, our first line is Ozurdex. And as far as you said about cholesterol, I think we have very convincingly shown that it does help in melting the hard exudates, but I don't know whether it's going to be something which is related to systemic issues and others. I can't answer that question.
Thank you so much, sir.